All right, guys, I think we'll get started. Everyone can just sign in and then we'll get going with the presentation. I just want to remind everyone that there's a House Staff Rep Committee meeting after this. It's going to be in CRTE room 152, so it'll be immediately following this. And then today we have Dr. McCoyd, who's the program director for the neurology department. He's been kind enough to give us a lecture day, and hopefully we can think like a neurologist when it's done. So thank you so much.
All right, guys. Yeah, so I'm Matt McCoyd. I'm the residency director, just what he said. So a couple things, just obvious. I know every speaker is going to probably say this. Number one, it's really weird to talk in front of people again. It's been a year and change. I do lecture for the medical school in one of these rooms. Pre-pandemic, everything was recorded. So it's typically talking to an empty room, right? So if you think popular lecture slots, 8:30 a.m. Monday morning after the Super Bowl, usually me and the IT guy. He's really good at MS now. So it's kind of nice to be in front of people. Also trying to remember if I get stage fright in front of people or not, which if I do is normal. It's just your amygdala. What I'm going to do over maybe the next hour is just go over some basics of neurology. I don't expect you to be a neurologist. First of all, that's probably a frightening thought for all of you or most of you, with the exception of the neuro prelims. Just go over a little bit of neurology. I don't expect you to be a neurology expert based on a single 60-minute lecture. It's a 4-year residency and a lifetime career for a reason. But it's just to try to go over some basic concepts I think can really help you as an internist or whatever your specialty is, as you're approaching patients, particularly at night in the ER, that may have some sort of neurologic challenge, right? So I love this book by Daniel Kahneman, Thinking Fast and Slow. It's a good book to work through during your kind of residency training. A lot of people quote Malcolm Gladwell with the 10,000 hours. Gladwell plagiarized it from Daniel Kahneman. Talking about the thing that's going to make you good as a physician is putting in time and effort. And there are no shortcuts to it. It's seeing enough patients in the ER, seeing basic cases, complex cases, working on your physical exam skills over a long period of time. That's just going to make you really good at your job. And if you're looking for personal satisfaction, getting rid of burnout, job satisfaction, be good at what you do. People who are successful tend to continue doing what they like doing. So, all right, what I have found to be true is I spend a lot of time thinking about neuro, and I'm still don't consider myself competent or an expert. So don't feel frustrated if none of this clicks that right away. A lot of stuff will change in neurology. Like the historic knock on us was we are the great diagnosers of disease, but we can't treat anything. I'll point out we actually have gotten pretty good at a lot of different treatments and are more advanced in a number of our things than other specialties. But one of the things that won't change are the core fundamentals, right? The basic bread and butter of neuro has been described for 100-something years. If you're good at these really basic concepts, they will never change. Imaging modalities will change, treatment modalities change a lot. Some of the therapeutics we have change, et cetera, but the basic fundamentals of how to approach a patient with a neurologic or medical problem, those are forever, right? So if you can master those, you're in a good place. All right. I kind of was stealing this slightly, tongue-in-cheek, from a CPC I attended, and was an internal medicine CPC, and the case was somebody who had ataxia. And the question to the group was, what's your differential diagnosis of ataxia, right? And so people start kind of chipping in. I'll tell you, as a neurologist, you kind of have one or two options. I think the knee jerk, particularly for recent medical school grads, is to go, okay, differential diagnosis of ataxia. All I have to do is memorize this chart, and I've got it. That works sort of well when you take USMLE, because you can memorize it for maybe 24 hours, but then it really doesn't do you any good. So your approach to a patient with a neurologic problem, you can try to memorize these massive remote lists that are sort of like memorizing the phone book, or you can try to have approach, right? So my role as a neurologist, number one, we get consulted. We see a patient in the clinic. Does the patient have a neurologic problem? Yes or no, right? That's a big moment for me. If the answer is no, I can refer them somewhere else, right? This is actually a shoulder issue. This is a spine issue. This is non-neurologic, right? Or two, it is a neurologic problem, which means ball's in my court. I have found this next thing to be true. This is incredibly important if you're approaching a patient with a neurologic problem, right? Is it neurologic? Number one, yes. If it's neurologic, diseases of the nervous system tend to affect one of two systems. They affect the central nervous system or the peripheral nervous system. It's a gigantic divide in neurology. there are essentially no disease processes that will affect both systems at the same time. So my big step as a neurologist is, all right, do I think this is central nervous system? Brain and spinal cord are affected. Or do I think it's a peripheral nervous system disorder, nerve, neuromuscular junction, muscle? If I can make that differentiation, I'm about 90% of the way home, right? There are only so many tests in neurology. This was a recent TikTok video, I think by a Loyola grad, the holy trinity of neurology, EEG, MRI, and LP. That is true. So what we're trying to decide is there a problem in the central or peripheral nervous system? And there's some areas where it's a little more challenging. Brainstem and spinal cord, for example, can be a little bit more challenging because of the overlap in the symptoms. But generally speaking, things are going to affect one system or the other. Central nervous system tends to be a bigger problem when you're on call because those are the things that will kill you quickly. All right, so what helps you tell them apart? Right, what helps you decide this is central versus peripheral, and therefore the severity of my illness and the route of approach I'm going to take on the patient? All right, so that's Charcot with Babinski standing behind him. The thing that really helps you is a physical examination. Taking a history and doing a physical really do make a big difference. If you order a whole bunch of tests, this is true in everything in medicine. If you just order a whole bunch of tests, CTs, MRIs, you're going to get a ton of information that doesn't help you. What you really need to do is localize first, then order your testing, because your testing confirms what you already know. So to do a physical exam, one, you got to get in the habit of doing it. Two, you definitely need a reflex hammer. How many people have them? So everybody who's a PGY1 has them, and everyone who's a senior resident does not, right? Okay. I have a stethoscope. I think it's in my office. Every once in a while I break it out, like to show medical students I have it. Hang on to a reflex hammer. They're actually really helpful tools. The bigger your hammer is, the better it's going to work. The little tiny light Pease hammers do not work, but the Taylor hammers, the Tomahawks, actually are really good hammers if they're big enough. So, okay. This is a pretty interesting paper from a couple years ago. You're going to get called to evaluate patients with altered mental status pretty regularly when you're on call in the middle of the night. One study, 40% of interns, when asked if they didn't do a neurologic exam. I would point out it is virtually impossible to not do some of the neurologic exam. Right? I mean, at some point, if you go evaluate a patient, you actually have to like walk in the room where the patient is. You just started the neuro exam, right? The neurologic examination starts as soon as you lay eyes on the patient. All right, for all of its nuances, right? And if you went to Loyola, I know PCM2 maybe goes over the neuro exam. Different medical schools do it differently, but there's a few different ways to approach the neuro exam. But this is what I do. You can complete a neurologic exam in about under 2 minutes. The biggest thing I would point out is that when you're evaluating a patient for altered mental status or a perceived neurologic problem, your exam starts as soon as you look at the patient because you're immediately gathering information. Right? I don't need to take the history and then suddenly shift into physical exam mode. You can do it all at the same time for efficiency. So number one, when you walk in the room, what does the patient look like? This doesn't matter if it's a clinic or in the ER. This person is, they're dressed appropriately, their hair is combed, they've shaved, they look appropriate, or they're disheveled and disoriented in the ER, right? That gives you information. Masking has sort of flawed this a little bit, but what does their face look like? Do they have facial symmetry? Do their eyes look the same? Are their eyes lined up correctly? Do they have ptosis? Does it look like there's facial weakness? Are they holding a limb a certain way where it's stiff and tight or sort of laying off to the side? You're going to pick up in your clinics, you're going to pick up Parkinson's disease. You're going to pick up Parkinson's during the history because that's when the tremor comes out. As you talk to the patient, all of a sudden you'll notice a rest tremor. The patient sees you look at their arm or their hand, it goes away because they can suppress it for a little bit. When the patient's talking, do they make sense? Are they able to have a fluent, coherent conversation with you, or are their words slurred? Are they not making any sort of sense? You can usually make the diagnosis of ALS during the history. Just listen to the way they talk. It has a distinct sound to it. All right, so once I've taken all my history, right? Usually during the history, I've got a pretty good idea what I think I'm dealing with. And at some point, you're going to actually start the kind of formal physical exam. This is a little trickier in the hospital, but not impossible. In the clinic, it's a lot easier. Patients are typically sitting in an exam chair. I do not like it if the patient's sitting on the exam table, because then to write our notes, the way Loyola is set up, I now have to put my back to the patient, type my note, turn around and ask them a question, type my note, turn around and ask a question. It totally destroys any sort of dialogue you're going to have with the patient. So ideally, they're sitting in a chair. If the patient's sitting in the chair, at some point in time, they've got to stand up, right? So use that to your advantage. If they're there for weakness, make them put their arms across their shoulders and stand up. Your patients who have proximal muscle weakness can't do it, right? What they're going to do is they're going to rock forward. They're going to put their arms on the side of the chair. They're going to push themselves up. Make them get up with their arms alone, without their arms, right? There's your hip strength. Next thing I like to do, and anyone who's been a Loyola student, if you've seen me, they're going to go walk down the hallway, right? So just get your patients to walk up and down the hallway. As they walk away from you, watch their gait. Does it look normal? Are they swinging one leg over to the side repeatedly? Is it sort of slow and shuffling? As they get a little bit farther away from you, have them walk up on their tiptoes, because now you can see under their heels. They just held all of their strength on their gastrocs. They've now got to turn around. You can watch the turn. What does it look like? Normal and fluid, or they have this sort of slow shuffling turn? And they can walk back to you on their heels, because now I can see underneath their feet. They just supported all their weight with their tibialis anterior, right? Their leg muscles are strong. As they get close to the door, I'll have them walk one foot in front of the other. The faster you go, the easier it is paradoxically. A lot of patients try to be perfect, like they're on a tightrope, and they will tip over. I've never had a patient actually fall doing it. A lot of patients with functional disorders fall into a wall. I've never had somebody fall through a doorway. So have them walk one foot in front of the other. That's a nice way to check balance. And then have them turn into the room, stand with their feet kind of close together, not quite touching. Hands out, spread your fingers and close your eyes. That's a Romberg sign. Patients who have problems with balance, but doesn't localize well, problems with balance can't do it. If you think a patient has a positive Romberg sign, right? Inability to stand with their feet kind of close together, arms outstretched, fingers spread, eyes closed. Ask them how they do in the shower. Patient will understand what you're saying. Patients who have this finding will say, oh, I have a grab bar, I have a shower chair, I wash my hair in the sink, I only take baths. Right? That's the same thing as a Romberg. Showers are Romberg machines. So great, now I've got a ton of information. I can sit them on the exam table and look at their eyes. Can't emphasize enough, I bet you senior residents will tell you they've had this happen at some point in time. When you admit a patient, take a look at their pupils, particularly if you're admitting them to the unit. Really comment on the pupils the first time you see a patient. I'm sure everyone's had an experience where like day 5 of the hospital admission, somebody says the pupils are asymmetric. And you're suddenly wondering if the admission note was right. And it's a big workup. So take a look at the pupils, ideally with the room dark. Try to do the fundoscopic exam. It's not easy. Most of us don't have ophthalmoscopes, particularly in the hospital, but still try to do them, particularly for your headache patients. Just try to do it. See if you can pick up papilledema in a patient who comes in for headaches. Take a quick look at eye movements. Look right, look left, look up, look down. Just make sure that they're symmetric. Things like internuclear ophthalmoplegias, I usually pick up during the history. Other cranial nerve abnormalities, you can oftentimes pick up just talking to the patient, be it a third or a sixth nerve. If you ever wonder what a fourth nerve palsy looks like, take a look at Abraham Lincoln. Look at a picture of Abe Lincoln, look at his left eye, it's slightly elevated. Got kicked in the head by a horse when he was young. So he probably had a fourth nerve palsy. That's just a fun fact. Anyway, next thing we do is, right, so all my cranial nerve stuff's done. I already know about facial symmetry. The motor exam. If they're there for weakness, take a look at their muscles. Do you see fasciculations? Do they have severe atrophy? Check their tone and then check their strength. I like to check the strength in the arms. Arms up, which is your deltoids, biceps, triceps, wrist flexion, finger extension. Because if I do that, it's every major nerve root, every part of the plexus. Then I can drop down and pull out my reflex hammer, check bicep, tricep, and brachioradialis. Just see if you can get a reflex. I go upper to lower, then I check the patellas and their ankles. For an ankle reflex, it's really important. You got to flex the foot a little bit. Just dorsiflex it slightly. If you let the feet dangle, you won't get it. You got to pull it up just slightly and tap on it. When you swing your reflex hammer, swing it through. A lot of people tap, they don't bend their wrist. You got to let your wrist snap a little bit. So that's my reflexes top to bottom. I'll check and see if they have a Babinski reflex. The sensor exam I find to be a little bit less helpful. I have a tuning fork. It's simplistic for me. Can you feel me touching your toes? Yes or no? If you say yes, that's great. Can you feel it at your fingers? Great. You can do the motor exam for the lower extremities, but the answer is you already did it. You saw the patient stand up, walk up and down the hallway. You already know a lot. And then you can go from there. The entirety of that exam takes you about 60 to 90 seconds if you do it correctly. So it doesn't take you real long. Just a nice screening exam for a neurologic disorder. The more you do it, the better you get at it. I'm going to go over a couple things on here that I find to be really helpful, right? So how do I help decide based on my exam, is it neurologic? Do I have a central or peripheral nervous system disorder? Things I find to be particularly helpful are altered mental status. It's got to be the brain. Do they have problems with cortical function? So they have difficulty with language. They have difficulty with a right-left coordination. Do they have any upper motor neuron findings? So that's brisk reflexes, upgoing toes. So anytime there's an upgoing toe, the problem in the brain or the spinal cord. It's pretty easy. Do they have a sensory level? Patient says, I'm numb into my abdomen. Spinal cord until proven otherwise. Is there a movement disorder? Some things that I find to be less helpful, cranial nerve abnormalities actually don't help you all that much. Symmetry doesn't help you. I've heard a lot of medical students tell me if it's symmetric, it has to be peripheral nervous system. It's not necessarily the case. It doesn't help you all that much. So what I'm trying to do is use a couple of cases here to highlight some points. So what are you worried about on call? You're worried about, is a patient going to have a major neurologic problem that's potentially going to contribute to their death or some sort of disability in the next couple of hours? So what always implies a problem with the central nervous system? Any patient who has altered mental status has a central nervous system problem, right? Something's wrong with their brain. Without getting esoteric that your breathing is so impaired that you're hypoxic and that causes your brain problem. If you're having a difficulty with level of alertness, there's something wrong with the brain. So that is like the common neuroconsult, right? Altered mental status, patient's really not responding. So my immediate approach to altered mental status, if a patient has a suppressed level of consciousness, be it they're in stupor, they're obtunded, they're in a coma, one of two things is going to do it anatomically. I need something that affects both hemispheres at the same time. So I need something that widely and diffusely suppresses brain function, both hemispheres. Or I need something that affects the brainstem from about the middle part of the brainstem up, the reticular activating system. It's got to affect one of those two things, right? So every patient you call us for in the MICU, altered mental status, that's my first thought. Do I have a diffuse brain problem or do I have a brainstem problem? So what would cause diffuse brain problems? Well, a structural issue can do it. Your patient has bled into their cranium and the massive quantity of blood is suppressing both hemispheres. So I'm getting a structural issue compressing both sides. Your patient's on hematology oncology. Did they just have a metastatic lesion into their cerebellum? That's spread. Cerebellum pushes forward into your brainstem, suppresses level of consciousness. Or most likely, is there some sort of metabolic disorder? Your patient is septic, they're hyponatremic, hyperglycemic, they're on multiple medications, and their brain is sort of bathed in an area of badness. That's my most likely answer. Most patients who are in coma, if you do imaging, the imaging is going to be okay. You do all sorts of anatomic localization, the answer is going to be none of the above. It's really going to be from a diffuse process, usually a metabolic issue or medication-related issue. That's what usually causes suppressed level of consciousness. What your exam is for is try to decide, is there any reason to think this is actually a structural issue? Those first two, there's a bigger problem in the brain. All right, how does that kind of help me? Altered mental status. I've got a diffuse brain problem or I've got a pretty focal brainstem problem. Well, I use a mnemonic simple. There's a gazillion mnemonics you can use. This one's gotten me through pretty far into my career. So I use the mnemonic simple as I approach altered mental status. Is there a structural problem? Patient bled, there's a massive tumor. Something big just happened inside the cranium, right? Is there an infectious or inflammatory process? I worry a lot about infections because those can kill you in the next 6 hours. Is there any reason this patient needs antibiotics and a lumbar puncture? Is it maybe an inflammatory condition, either due to medications, multiple sclerosis, or other causes? The big one, is it metabolic or medication? We did it. We put the patient on antibiotics that increase the risk of seizures. We put them on something that altered their glucose, altered their sodium. Is it a medication or metabolic disorder? Is it paroxysmal, something that comes and goes? So it's the patient seizing. Right? Not every patient who seizes has focal shaking of the arms and the legs. There's something called subclinical status. If you're wondering why we order EEGs on all your altered mental status patients, right? And it always comes back with the same report. There's diffuse slowing that's non-specific in nature. That's great. That's what I wanted to say. It should be diffuse slowing. The patient's not awake. They're not alert. They're obviously slowed cognitively. What I'm worried about is, are they in subclinical status epilepticus? I actually need to treat an underlying seizure that isn't manifesting with motor manifestations. Is this a late onset neurologic disorder? You've got a patient with underlying dementia who's 85 years old, who has a urinary tract infection. You put in 4-point restraints in a soma bed with the TV running 24 hours a day and the shades drawn, and they're getting more and more confused. And the answer is we got to address that. Or is it some sort of early onset neurologic disorder? And those are very, very rare, which is why it's last on my list. What do I then do with that mnemonic? Well, if I'm worried about a structural problem, that's why we get CTs and MRIs on patients. If I'm worried about an infectious etiology, does this patient need a spinal tap? Do I need to simply start antibiotics prophylactically? Medication or metabolic disorders, I should be able to pick that up with a MedRec and basic lab work, right? Ammonia, thyroid, basic metabolic panel. Is it a paroxysmal disorder? That's why I need my EEG to help me out, right? Can I at least confirm that this is what I think it is? Is it a late onset neurologic disorder, right? It's a demented patient who simply we've made more confused and altered in the hospital. Is it an early onset neurologic disorder, in which the answer is we're probably not figuring it out in the middle of the night. Let's just try to keep the patient kind of quiet. So with that in mind, you're consulted for a 65-year-old male who's not right. He was admitted following a fall with a fractured elbow. He's arousable but can't maintain attention, often drifts off to sleep. He's able to answer some questions and follow some commands, but answers are sometimes inappropriate. He'll use the wrong word or use odd phrases, or he's simply difficult to understand. He doesn't complete all the commands you give him. He can remember a few words immediately, but not a few minutes later. There's no apparent focal weakness. His wife says all of the above is different for him. So, number one, is there a neurologic problem? Yeah, this guy is confused, and it's not from his elbow, right? Your elbow doesn't affect your brain, to the best of my recollection. So yeah, he's got a neurologic problem. Is it central or peripheral? Right, so big group should be an easy answer. He's got altered mental status. He's got a central nervous system disorder, right? Something's wrong with his brain. So what do you want to do with him? Well, I don't know, we should probably get some sort of imaging. So maybe a CT or MRI, maybe just a simple CT scan. Do I think there's any chance he's got a CNS infection? I'll put it out there. Maybe this is medication or metabolic related, right? That's my big go-to. I don't find anything else focal on his examination, nothing else in his history that's suggestive. I don't need to call an acute stroke. I don't know how long this has been going on for. So maybe this is a simple metabolic issue. Turns out the guy has Wernicke-Korsakoff syndrome. He's got a thiamine deficiency. I didn't give you a lot more information, but you start to think along those lines. Maybe this is more metabolic. Wernicke-Korsakoff is a really common cause of altered mental status. It's a diffuse brain disorder. Kind of cool fun fact, it also causes thalamic lesions, which is like my favorite thing to do. But what I want you to focus on is, all right, well, guy with altered mental status, yes, it's neurologic. Yes, it's central nervous system. So I either have to have a structural issue, infectious, inflammatory, metabolic, or medication kind of issue. What am I going to do? I'm going to do imaging. I'm going to do some basic blood work. I can think about these metabolic derangements as my most likely cause, right? And it's that easy. All right. Second thing, cortical findings means central nervous system. So the outer part of your brain is what makes you, you, right? That's what's letting you pay attention to what's on the screen, hopefully understand what I'm saying. And if you were to talk to somebody, you could actually speak words back. So cortical findings are brain disorders, right? So can the patient understand and produce meaningful language, or are they aphasic? I find that to be the biggest challenge. Is the patient aphasic, or is the patient simply confused? I find that to be one of the harder things to decide clinically. And if I'm not sure, I'm going to default to the patient's aphasic. Does the patient recognize his environment, or are they neglecting? Do they not notice anything off to the left side? Right. So if you talk to the patient on their left, they won't talk to you. If you talk to them on the right, they will. I had that happen with a guy who had a carotid dissection. You stood on his left, he wouldn't talk to you. You stood on his right, he was fine. If you got him to maintain eye contact, he would actually turn to his right in the bed and try to look at you out of his right eye because he wouldn't look out of his left. Can you see both halves of the world? Is there an obvious visual field deficit? All right, not to knock the neuro exam, but I know a lot of people do the like, can you see this finger, that finger? I've never had a patient not tell me they couldn't see one side of the world. I just ask them, how's your vision? I can't see one side. Okay, that's bad. Okay, with this, never mind. Do they understand how to use objects, right? Or do they have an apraxia? Any of these things would make me think something's wrong with the brain. So focal lesions cause focal symptoms. That That slide got flipped. I'm going to give you a case example. This is a real case, 27-year-old female. She gave birth to a healthy baby boy a couple weeks before she came to the ER. Her husband brought her to the emergency room. Husband said she got up to feed the baby. Shortly thereafter, she came to get him, and he knew something was wrong. So the ER called and said the patient's confused. I like making fun of the ER. The ER called and said there's a confused patient, unclear if it was the ER that was confused or the patient. So we went and talked to the patient. On exam, she's awake and alert. She was sitting up. She could make eye contact, right? You would ask her questions and she couldn't answer. And she was clearly frustrated, right? You got the sense she understood the questions, but couldn't get the words to come out. And again, she's awake, she's alert, she's otherwise following commands. She'll do stuff with her left hand, but not her right. And she's got right facial weakness. So she has right facial weakness. She's got right arm weakness. She's not talking. So really simplistically, does she have a problem? Yes. Central peripheral nervous system. Well, it's central nervous system, right? She's aphasic. It has to be in the cortex. And there's right face, right arm weakness. Sounds like it's probably going to be a stroke. So does she have a problem? Yes, she does. So what's the most important thing you should try to immediately establish with her and her husband? And this is something you should do in the hospital if this comes up. Really want to know what time it started. It's really critical to try to document that. We do get a lot of acute stroke codes in the hospital. We go talk to somebody, we go, when was the last time we saw them normal? People go, I don't know, like a day ago. You're like, okay, well, acute stroke just ended. We really need to know the onset. We're hoping for stuff under 3 hours. We're willing to go 4.5. We can push it a little farther now. Loyola can do bells to whistles intervention. We have the ability to take patients down to the OR for intracranial thrombus resection. So we've got a fully operational kind of stroke unit here, but you really want to know and establish what time do I think this started? I really got to get a clock started. So what time does symptoms start? Time is brain. We really want to act on these quickly. The big challenge for us in the hospital, for you guys in the hospital, the nurse will come and say, hey, the patient's altered. I think they had a stroke. All right, do we have any idea when this started? And the answer is no idea. All right, well, we don't have a good window here. So it's going to be challenging. This is a real example of something that happened. That is Northwestern's mobile stroke unit. Super fancy, right? That's me with a pirate shirt because that was our Little League baseball team, and a pair of, I've got hangers in my hand. The Northwestern mobile stroke unit's muffler broke in front of my house, which is an amazing coincidence. I was like, hey, I'm a neurologist. What's going on? They're like, our muffler's broke. Oh. My kid's got a cool tour of it. It's great. Things totally useless. Okay. Anyway, so what happened with this patient? So pretty quickly, somebody said, all right, well, sudden onset. The husband says, yeah, it was at like 9, and this is like 9:30, 9:45. She's aphasic with right-sided weakness. This is a stroke. The picture on your top is her middle cerebral artery, and it stops, right? It gets blunted. If you look at the bottom picture, yes, you can see more blood flow through the vessel. That was after she got intra-arterial TPA. She went from being aphasic to speaking. Strength got better actually in the operating room. And then she was speaking French the next day. She didn't learn French. She knew it. There is a stroke syndrome where you pick up a foreign accent. It's usually Dutch. Nobody's sure why it happens. I heard it once. Woman speaking sounded like Dutch. I said, when did you immigrate? Family said she's from Cicero. So, okay. So anyway, it's a weird thing that happens. All right. The other one will be, if you're worried about acute stroke, call it. Don't call an acute stroke just to get a head CT. Surgery does this a lot. Just so you're aware, when you call an acute stroke and activate that stroke pager, it activates like a massive system. There are like OR techs, pharmacists, administrators, surgeons, like a ton of people get notified. So surgery does this to us all the time. We're like, hey, what's the emergency? It's, oh, we just want to get the head CT done. It's not an emergency. You're like, okay, we'll just de-escalate the entire hospital at 2 a.m. Okay. Our cranial nerve, central or peripheral. This is, I think, a point of confusion. It doesn't really help you if there's something's wrong with the cranial nerve. Their eyes aren't moving normally. Their face is asymmetric. Something's wrong, right? Those are pretty specific findings, but it doesn't really help you if it's central or peripheral. But either way, something's wrong, and we're probably going to go down the pathway of trying to figure out what it is. So, okay. Next big rule in neurology: the right side of the brain controls the left side of the body. Right? That's really important. If you don't remember that, neurology is really, really challenging. There's one exception to it. You guys will see Horner syndrome. You will see Horner syndrome more than you realize. Look at your particularly hematology oncology patients. they oftentimes, not that often, but often enough, they'll get slight ptosis of one eye and the pupil's a little asymmetric. It can be from a lesion anywhere on the same side. It's the only pathway that doesn't cross. I've seen it a couple times on HEMONC. Patients with lymphomas, it infiltrates the foraminal space at C8T1. They'll get it from there. I know the famous USM Elite question is a Pancoast tumor. I have seen one of those in 20 years. I picked it up on an EMG, oddly enough. But any sort of lesion can potentially cause a Horner syndrome. The cool thing about Horner syndrome is it tells you the problem's on that side. You don't have to worry about where things cross. But right side of the brain, left side of the body, one side should look like the other. Symmetry is the rule, right? Asymmetry is always bad in neurology. So one thing that I think to be particularly aware of, because this can come up for a number of different cases, the cranial nerves are on the same side. They don't, without getting esoteric, they don't cross. So if you have a cranial nerve finding on one side, the problem is on that side. But in your brainstem, everything is crossing. So for brainstem disorders, you can get cross brain findings. The big thing to ask a patient who comes in for like severe neck pain and says, hey, my face is numb. Okay, how's the other side of your body feel? Right, so you get this cross brain finding, cranial nerve on one side, body finding is on the other side. Why is it important? Maybe this shows up in to you guys as opposed to us. 37-year-old, she came in, she had some non-specific neck pain. A few days later, she's driving. She has difficulty holding a bowl of oatmeal. She's a passenger in the car eating and can't control the bowl. She then noticed some numbness of her right face, and then her left arm went numb. So concerned, she said, something's wrong. And they take her to a local emergency room where the ER tells her it's probably a psychogenic disorder because she was going through a divorce. Okay. Right side of her face is numb, left side of her body is numb. She can't control her arm. Does she have a neurologic problem? Fortunately, somebody said, well, you should probably call neuro too. And neurology said, yeah, there's a major neurologic problem. She has cross brain findings. One side of the face, other side of the body, that's a brainstem disorder. Again, I like making fun of the ER. She had a vertebral artery dissection. So she dissected her vertebral artery, strokes her brainstem. As a result of that, she knocks out the trigeminal nerve of the face, the spinal thalamic tract on the other side, knocks out essentially her cerebellum, and she has a Wallenberg syndrome, where she gets a cross brain finding. There was a patient actually admitted, I can't remember who ended up taking her. It didn't go to neuro for some reason. It either went to medicine or like ortho or something weird, like probably medicine based on the story. I don't know how this person gets transferred in. This was a couple years ago. The resident was Amy Brown, who's now a faculty at Vanderbilt. This woman is fishing, right? And while fishing, her face goes numb and then her body goes numb, other side. So right face, left body, same story. Goes to a local ER and says, you know, all of a sudden this has kind of happened. They do a neuro exam, most of which is normal. Eyes move normally, face looks symmetric. But she says, this side's really numb and this side's really numb. And they're like, that's, you know, two different sides. That's insane. This is psychogenic. Patient complains. They say, fine. We're going to transfer to Loyola, a higher level of care, which sounds like a way to punt. I don't know how this goes to medicine. Everything goes to you guys, right? Sorry. I try not to do that, but you know. Okay. Anyway, so somebody finally calls neuro and says, listen, whatever. Again, the neurologist goes and goes to Caesar and says, what's the story? She says, the side of my face is numb, the other side of my body is numb. It's like, well, that sounds like a brainstem stroke. CT scan, sure enough, you can see evidence of a stroke, but it's bigger than the last one. It's now knocked out the vertebral artery and one of the cerebellar arteries. So she just had a massive stroke in her cerebellum. Problem with cerebellum is it's a pretty big structure in a tight space and it expands with the stroke because there's edema and starts herniating forward. So she actually goes to the OR that night for a subcranial or suboccipital craniotomy, right? So big deal. She actually would have, I mean, you know, there's not that many dramatic things that happen. Most of the time it's like cure patient's constipation. But like this was legit, like this person probably dies overnight unless somebody actually listens to the story and goes, hey, that's a really classic finding and a really common disorder. We see this a lot. So the first patient was thought to be from a chiropractic procedure. We also like to blame chiropractors for everything. They're probably fine, but whatever. She just wanted an aspirin and it was fine because aspirin's usually the answer anyway. But it's a big deal, right, that it was picked up, particularly that second case. The other one, why do I really like reflex hammers? Pathologic hyperreflexia is always a big deal. If you examine your patients in the MICU, particularly those in coma, you're going to find they oftentimes have bilateral Babinski findings. So once you see that, you know something is wrong. And you know the problem is in the very specific, if you care, it's in the cortical spinal tract, somewhere in the spinal cord of the brain. But you have a definitive absolute central nervous system disorder, right? So your comatose patients, it's probably from the coma, but other patients, it's a focal neurologic deficit. It really makes you think there's a problem somewhere in the brain, or there's a problem somewhere in the spinal cord. So I hear a lot that it's normal to not have reflexes. That's actually not true. It's never normal to not have reflexes. The reason older people don't have reflexes is they have neuropathies, radiculopathies, tendinopathies. They've got medical problems that reduce their reflexes. Asymmetric reflexes, hyperreflexia is always abnormal. Right? Okay, a couple things. I already harped on this once. You do need to just humor me and just say you have a reflex hammer. Like if you come rotate with us in neuro, borrow somebody's reflex hammer. I don't care about your stethoscope, reflex hammer. The bigger the hammer, the better. There's a bunch that are out there. I like Taylor's and Dejerines. Most of the medical students will literally have a Dejerine hammer. There's really good trauma hammers, but those are a little harder to find. Positioning is the entire thing. You've got to get the patient relaxed and positioned right to potentially get them. And it all has to do with how you swing your wrist. Too many people keep their arm and wrist static. There's no flex. It won't work. All right, just a fun story I like to tell because I have time. How did Babinski describe the Babinski? If you're a Loyola student and you're rounded with me, I know I tell this story pretty much every day on rounds. The old French ward system, the hospital beds lined up, the feet face towards the middle. Charcot would take morning rounds and he would say good morning by tapping people on the bottom of the foot. Babinski stood behind Charcot for a number of years. And he noticed that some of the times when he did it, the big toe would go up and the other toes would fan, right? So he just was standing behind Charcot forever. And then he went back and examined the patients and he wrote a 28-line paper that said, I think if the toe goes up, there's a problem in the cortical spinal tract. So that's the Babinski sign. He's probably the most famous neurologist ever, right? If you ask somebody, do you know what the Babinski sign is? Most medical people know it, right? Even if you go into ortho and forget everything about medicine, you still might remember that one, even though you don't know what it is. So Babinski is the most famous neurologist ever. He never passes his board exam because his last name is Polish, so the French wouldn't pass him. He actually had an incredibly established career. Charcot, super famous, like everything is a Charcot sign. He missed the most important sign in neurology just by getting it every single day. So you can do a lot on rounds. Plus, it's just kind of a fun story. All right. Going back to some of those kind of key lessons about reflexes and other stuff, a 40-year-old female presented for left leg numbness. She states the symptoms have been progressive over the last several weeks and she felt it was time to get it checked out. On examination, she has decreased pin sensation to just above the left hip, involving the lower abdomen, kind of right around the belly button. There's mild right leg weakness, asymmetrically increased right lower extremity reflexes with an upgoing toe on the right, with impaired vibratory sense on the right as well. So first of all, you're all getting flashbacks to the second year of medical school right now. But really simplistically, as a physician, does she have a neurologic problem? Yes. Is it central or peripheral nervous system? She has a sensory level. She says she's numb to her hip and she has an upgoing toe. She has a central nervous system problem, period. And then the kind of next level is, well, she says she's numb in her abdomen. That's a spinal cord disorder. So without worrying about which tracks and what level, there's something wrong with her spinal cord because she says she's numb into her abdomen and she has an upgoing toe. And I don't care which side they're on, there's a problem. So I've got to get imaging. If this is someone who comes to the ER and says, listen, this sort of happened in the last couple hours, she needs to go into a scanner like right now. There's no wait. There's no like, well, we can't get her. She's no. Intubate her if you have to. She needs to get imaged. Her story was a little bit more progressive. So does she have a problem? Yes. Sensory level, upgoing toe, definitely neurologic, definitely central, definitely spinal cord. What other questions do you want to ask her, which I'll get back to? That is her imaging. Normal or abnormal? The only reason you show imaging is it's abnormal. She has a massive tumor in her spine. Right, gigantic Goomba, that's easy. That's the tumor. That's her spinal cord. Tumor grew, pushes the spinal cord to the side, compresses one side. She develops a Brown-Séquard syndrome. But the big thing was she's a sensory level and upgoing toe. You know it's a spinal cord problem until proven otherwise. What's the big question I always try to emphasize a lot in the clinic? When patients say they've got numbness in their legs, really try to emphasize with them how high up does it go? Does the numbness get into your abdomen? Yes or no? Then I think I've got an example of this coming up. A lot of people think Guillain-Barré is ascending numbness and weakness, which is true, but it doesn't come into your torso. So if your patients come into clinic or into the ER and they say, my feet are numb, really try to establish, well, how high up does that numbness go? Once they give you a story that it's into the abdomen, into the chest, into the back of the head, there's a spinal cord problem. That's a big neurologic emergency. Spinal levels are really particularly important. The rest of the sensory exam I find to be a little bit less intriguing. I find the pin exam to be not all that helpful. I do it sort of if I feel like I have to, but not often. I really am trying to emphasize if there's a spinal level. If they have a spinal level, if there's a myelopathic disorder, something's wrong with their spinal cord. If it's something that's going on acutely, which you don't know if it's extrinsic, something's compressing the cord like an epidural hematoma in your anticoagulated patient, or something intrinsic, there's a new lesion inside the cord. You cannot tell clinically, they have to get imaged. Old neurologists used to use that tool on your right, which is called the Wartenberg wheel. They would start it at the toes and they would just roll it up the patient's leg and body until the patient could feel it. The reason we don't use it all that often anymore is they would go from patient A to patient B to patient C to patient D, rolling this wheel up. And then you can imagine the skin diseases we spread along the line. So not used. All right. So 32-year-old female came in for gait instability. She first noticed numbness in her feet, progressed over 24 hours to involve her legs and then her hands. Examination was notable for impaired vibratory sense at the toes, ankles, knees, pelvis, at which point I'm getting nervous. Her rib, she doesn't feel the tuning fork. And then the knuckles of her hands. Reflexes are normal. ER says, hey, she's got ascending numbness. It's probably Guillain-Barré. But it can't be. Guillain-Barré doesn't cause numbness in your torso. It always affects your reflexes. So our concern was she definitely has a central nervous system disorder. It's something affecting her spinal cord. And actually had a lesion right in the back of the spinal cord. She had an inflammatory transverse myelitis. She actually is never fully recovered. So if somebody says they're numb, particularly nuance that, hey, I've got numbness in my feet, that's ascending, really try to establish how high up does it go. It's a big deal. All right. One other thing, if you sort of remember your neuroanatomy, the patient said they were numb. That first patient I said was numb to about belly button. That's supposed to be thoracic spine. Good rule of thumb, if you're worried about a spinal cord disorder, image the level you think the lesion's at and just go one level up. I find whole spine imaging to be useless. I know it's ordered a lot. So we'll get the entire spine. There's no spinal cord in your lumbar spine. If you're worried about conus medullaris, because there's bowel and bladder dysfunction, or you're worried about cauda equina, which is really just a lumbar radiculopathy, order imaging of the lumbar spine. The patient has a sensory level and brisk reflexes, order the cervical and the thoracic spine. The lesion is usually higher than what you think it's going to be. That has been my experience without fail. All right, so I'm going to finish on time, in fact, a little early. So where does ataxia localize? That was the first thing we mentioned, right? So it doesn't. So ataxia just means incoordination of movements. And the reason why it gets complicated is you need more information. You need to take a history and do a physical examination. Ataxia just means there's incoordination of movement. So think about all the things you need to do to be able to stand still, right? If you're just standing, the nerves in your feet and legs have got to send information up the nerve into the spinal cord. That message has got to go up the spinal cord where it splits, some of it going to the cerebellum and some of it going up to the brain. All that information's got to route around. Cerebellum projects it back to the brain. Brain decides what it wants to do through the basal ganglia. It backfires down the cortical spinal tract, down the spinal cord, back out to the peripheral nerve and tells your feet to stay where they are. It's a massive system. Anything that gets thrown off will cause you to have incoordination of movement. So it doesn't help you. So now I need ancillary information. What's your reflex exam look like? What's your sensory exam look like? Is there any other part of your history or physical? Right? And you can come up with these huge and broad differentials. They don't matter until you get more information that helps you localize a little bit farther down. So, all right. Bromberg machine, I think I already talked about. All right. I tried to make this kind of simplistic and quick. I think the reality is you're going to find this true for everything you do in medicine, that there are no really simple, easy answers. At the end of the day, just do your best to be a physician and try to make your best decisions in the moment. There's no kind of easy, quick way to do it. So the more patients you see, the better off you're going to be. The more exams you do, the better you're going to get at them. The more things that you see. Even when you see kind of boring bread and butter stuff, get good at it. The bane of a neurologist's existence is dizziness. So I've got a plan for dizziness when I see somebody, because I want to be able to go after it. I imagine for internal medicine, it's GI pain. Have a plan. See a lot of patients, see interesting stuff, see esoteric stuff, see bread and butter stuff, and have a plan for how you're going to approach it every single time. So that's it. Faster than I thought I would be. any questions I can answer to a large, massive group. If there are, if you guys need any help with any of this stuff, or you have a case you think is interesting, please feel free to contact me or grab one of our residents. We're happy to go over this stuff with you. If you happen to rotate with us in neuro, either hospital or now increasingly over in the clinic, let us know. We're happy to go over some of these exam findings and try to help you get a little better at handling some of this stuff. Sound good? All right, guys. Is Alex here?